chairman of the GU tumor group, Phil.
Just.
And he's going to tell us why radical prostatectomy isn't enough.
Well,
always,
yeah. And the reason that I'm pleased to be here is that in the last year there have been 3 randomized trials and 2 large phase 2 studies which have been published, and things have changed. And what I'm hoping to do is leave time to discuss a treatment algorithm. So you may be surprised to learn that not everybody is cured by radical prostatectomy, and Martin gave me these data from the QOG 3 versus 8 month study, and I just redrew these, grouping the 3 and 8 months together to show you that at 5 years about 25% of low and intermediate risk cancers have a biochemical relapse, and for high risk cancers it's 50%. Right. This is community practice. I think we've got an automatic timing on it here actually. I'm just going to stop this for a second because I think you've set up the slideshow automatic times. So manually. I guess. Okay. Thanks. That's all right. Yeah, take 2. And this is important because if we look at PSA relapse, this is Towns data, and here we have a median time to metastases after PSA relapse of about 7 or 8 years. So PSA relapse is not always a benign phenomenon. And if you look at the time to secondary therapy, about 40% of patients who have a radical prostatectomy will eventually have some secondary therapy for prostate cancer. And this is bang up to date, although of course it reflects practices over the last 10 and 20 years. Other sources of data are from capsule, where adjuvant radiation therapy is used in about 6.5% of all patients and 13% where the margins are positive. And then subsequently for secondary therapy, another 14% split, roughly 50-50 between radiation and hormone therapy. Here in BC, we have data looking at the use of curative radiation therapy after radical prostatectomy. And back in the early 90s, 30% of patients who had radical prostatectomy would come and get post-operative radiation therapy. And that has substantially changed over the last decade. And that's changed for a couple of reasons. There have been advances in surgical technique, but there have also been advances and changes in the risk grouping of prostate cancer. If we take clinical stage 1 and 2, which is on the left-hand side here, and then look at the margin positivity rates over the last 20-30 years, you can see, and this is data from Hahn, that the margin positivity rate has decreased substantially with each decade. And with that, the organ-confined PT1 and PT2 has increased over the last decade. But on the right-hand side, for the clinical stage 3 cancers, that margin positivity rate improved in the 1980s, but has stayed at around 25% ever since. So the more advanced cancers still have a substantial margin positivity rate. So, what should we do for these guys? Well, I'm going to talk about one phase 2 study, which is our work, which was published a few years back. Isabel Syndicus was a fellow at the Cancer Clinic, but this was really Lorne Sullivan and Ed Kosterchuk's work, because back in the 1980s, they decided to look primarily at toxicity, and they took 203 consecutive patients. So this was a prospective, non-randomized study. Basically, some were followed and just had surgery, some had early adjuvant radiation therapy, and some had salvage radiation therapy. And they were selected for those 2 treatments on the basis of the pathological criteria. This was old-fashioned radiation therapy using large fraction sizes with old-fashioned techniques, which may impact upon the toxicity, but I doubt if it impacted upon the cure rates. So as you would expect, these 3 groups differed in terms of their baseline characteristics. The adjuvant group had much more often had positive margins. The seminal vesicles were more often positive, and there was more often extracapsular extension. The salvage group, who were followed until they had a rising PSA and particularly a palpable local recurrence, because this study was done in the late 80s and early 90s, they also had bad prognostic factors. But when we come to look at the outcomes of the surgery-only and the adjuvant radiation group, we found that early radiation therapy, in spite of having those worst prognostic factors, these guys did better, and that was statistically significant. Now, if we waited until they had a palpable local recurrence or a raised PSA, they did really badly. So one of the messages from this phase 2 study, relatively small, is that it appears that the early use of adjuvant radiation therapy is beneficial, at least in terms of freedom from first failure, which is basically PSA relapse for many people. And if you leave it until they have a palpable local recurrence, it's really too late. We did a multivariate analysis, and as you'd expect, a higher PSA, preoperatively, seminal vesicle involvement, lymph node involvement, and positive margins were adverse, but also the use of early post-operative radiation therapy halved, almost a relative risk of 0.4, the risk of subsequent relapse. And I want you to remember that figure of 0.4. We looked at toxicity. This was really the aim of the study, and there was, highlighted here in yellow, a significant increase in grade 4 GU toxicity, which is basically obstruction requiring a transurethral resection or a dilatation. And there was a marginal increase in grade 2 GI toxicity. Grade 2 would be intermittent rectal bleeding or diarrhea not requiring intervention with medication like Ometil. And impotence rates also increased. There was a big review which Chris Parker, who is a fellow at PMH and now at the Royal Marsden Hospital in the UK, did of the use of adjuvant radiation therapy. And he actually commented that the Vancouver results had unduly high toxicity rates. And this, I think, is due to this old-fashioned hypofractionated technique which we no longer use. Now you're familiar that Pound and also more recently Catan has used the Pound data to put these adverse factors into a nomogram which we can use when we have the pathological information and the pre-treatment information to predict outcome. And those factors which are known to be adverse, obviously the PSA, the Gleason, the percent positive cause has emerged as a very strong independent factor in the last few years. The T-stage, and then the post-op pathology, the nodal stages, of course, margin positivity, seminal vesicle positivity, and capsular penetration, which could be focal or established, and the post-op PSA kinetics. So what I want to do is look at adjuvant radiation therapy, salvage radiation therapy, and hormone therapy, and then tie it all together. So adjuvant radiation therapy, what I'm talking about is post-operative radiation for node-negative patients following radical prostatectomy who have an undetectable PSA, typically given within 6 months of the surgery. So planned adjuvant rather than waiting for the PSA to rise or subsequent clinical relapse. There has been a whole slew of phase 2 data, and this is all we had up until a year ago. Unfortunately, we can move away from these small studies to randomized trials. The first was presented at ASCO a year ago and also at ASTRO from Europe. 1,005 patients with a median follow-up of 5 years. So a very mature data set, well, relatively mature data set. And patients in this trial were given post-operative radiation therapy or not, 60 gray, and they had various combinations, which is why the figures add up to more than 100% of seminal vesicle involvement, positive margins, or capsular invasion. The grade was, as you'd expect, mainly intermediate and high grade, and these patients were well balanced. Just looking at toxicity first, there was an increase, at least a statistically significant increase in grade 1, 2, or grade 3 toxicity. But the absolute numbers here are pretty small. Grade 3 toxicity at 5 years, a 4% risk is pretty low and certainly acceptable. But looking at relapse, there was a really marked decrease in the time to relapse from about 48% down to 28%, and the hazard ratio there is 0.5. When we look at local regional failure, a greater effect. Of course, local relapse is difficult to assess, particularly if patients are at risk of metastatic disease and getting hormone therapy. But as you see, quite a marked divergence in the curve, with approximately 1/3 the rate of local relapse in those who had adjuvant radiation therapy. So summarizing these results, the use of post-op radiation therapy decreased significantly the chance of biochemical relapse, progression-free survival. There was an increased toxicity, but I don't think that's clinically important, although it was statistically significant. And there has not been enough deaths yet at 5 years median follow-up to get meaningful survival data. That hazard ratio of 0.5, not dissimilar from the 0.4 from our phase 2 study. The second study was presented just a couple of weeks ago at the AUA. This is what we know in Canada as the PR2 trial. It was run through SWOG as well as the NCIC. This trial took place over 10 years ago. Patients who had positive margins or positive seminal vesicles or extracapsular extension were randomly allocated post-operative radiation therapy or observation. And this was sort of more modern radiation therapy. I just put in the point here, there was no stratification by pre-radiation PSA. The primary endpoint of this trial is metastasis-free survival, and we have been waiting a very long time for this study to be reported. In fact, the median follow-up is 9.7 years. A large number of patients, but not as large as in Europe. I'm sorry. It's pre-radical prostatectomy. Yeah, thanks for picking that up. And these patients were followed to death. And the reason we've been waiting so long for the results is because, at the bottom line here, the overall survival and the metastasis-free rate did not reach statistical significance. But if you look at this, you'll see that the PSA relapse rate was substantially reduced. Again, the hazard ratio of 0.5. Progression-free survival, hazard rate 0.59. And although for both metastasis and overall survival, the difference is not statistically significant, it's in the right direction. And there is quite a substantial decrease from 74% to 63% in the survival rate is, I think, quite an achievement because, as you're aware, it's very difficult to get a survival endpoint for prostate cancer, particularly in the elderly. You're probably aware of the Holmberg data from Sweden, which was updated just a couple of months ago, and the only groups that had a survival benefit for radical prostatectomy was men over the age of 65. I'm sorry, under the age of 65. Over 65, if you look at the curves, there's no hint of a survival benefit, but we all know that those people benefited from radical prostatectomy in terms of quality of life and so forth. The third trial presented at ASCO earlier this month was much smaller, and the median follow-up is only 3 years. Patients once again were selected if they had pathological T3 cancer and an undetectable post-operative PSA. They got 60 gray, which was delivered 2 or 3 months later. This was a well-designed study. But it was interesting, they were randomized post-operatively, and so there were about 300 patients, and 140 were randomized to adjuvant radiation therapy, but only 108 got it. And when they looked at it, apparently, this is directly from the presentation, 32 were told by the urologist not to have the radiation after they'd been randomized. I don't know why. Yeah, well, it may be they were randomized so soon post-operatively that perhaps, consent, I don't know. And then of the 153 randomized to no therapy, 6 actually had radiation therapy. So when they looked at the intention to treat analysis, there was a significant improvement from the use of adjuvant radiation therapy. But when we look at the protocol delivered analysis, which was basically just looking at the 108 rather than 140, there was a significant improvement.
When you're saying adjuvant, is it within 3 months, 6 months,
yeah.
a year?
This was actually, the design was within 2 to 3 months. All were within 6 months. This particular German trial was within 3 months. I think the NCIC trial was within 6. And here the hazard ratio of 0.4 is identical to the phase 2 data from BC, which is interesting. So we've got a lot of consistency here. There was toxicity, again, the grade 3 toxicity, 2 or 3%, I think is well within the sort of 5% that most of us consider acceptable. And the significant factors on multivariate analysis, as you would expect, probably initial PSA, the higher the PSA, the worse. And so, I'm sorry, that's the opposite of what you'd expect. These are predictive factors of benefit, and so people with lower grade cancers, with negative seminal vesicles, but with margins that were positive, in other words, they had something to treat, appeared to benefit. And I don't know why those with a higher PSA rather than a lower PSA benefited. And then there was a fourth trial, and this was a 3-arm trial that was started by the RTOG a few years ago, and it accrued very poorly, so they dropped the middle arm, the hormone therapy arm, and it still accrued badly, so unfortunately a year ago it was terminated, having accrued only a handful of patients. So just to summarize those 3 randomized trials, they really are in agreement. There's a 50% decrease approximately in the PSA failure rate and about a 40% decrease in the clinical relapse rate. And that most mature trial that we've seen, which is the NCIC trial, showed this 10% absolute improvement, although not statistically significant, in metastases and overall survival, not just prostate cancer death, but overall survival. So we could perhaps argue that every man who has positive margins or PT3 cancer should get radiation therapy, but we'd probably end up treating many more than required therapy. So the alternative may be salvage radiation therapy. What about waiting for the PSA for a clinical relapse? And there are two sorts of salvage radiation therapy. There's early salvage, which is when the PSA first starts to rise, and then there's late, or I would argue perhaps too late, which is when the PSA is above a value of 1 or 2 or 3, or certainly if they have a local palpable relapse. And as we've seen from the phase 2 data, those guys do pretty badly. So Alan Pollock last year presented the largest series of adjuvant and salvage patients in the literature. They'd all been followed for at least a year. The vast majority had had salvage radiation therapy, and of those you could divide it into two groups: persistent raised PSA and a delayed rise in the PSA. And then a smaller number had adjuvant radiation therapy, which he defined as within a year with a PSA less than 0.2, and these patients were followed for a median of 6 years. He was able to group these patients using recursive partitioning into prognostic groups which varied from a very high biochemical control rate, where the PSA post-operatively was very low and there was no seminal vesicle involvement, and generally also of low grade, right the way through to group 5 here with the Gleason 8 to 10s, where they had a very poor biochemical control rate. And it's interesting to see that the Gleason is really driving that rather than the PSA. So the adverse factors on multivariate analysis for metastasis, just as you'd expect, Gleason 8 to 10, negative margins, because if you have a raised post-op PSA, you'd like to see it coming from a positive margin rather than from occult metastatic disease. Similar for overall survival. And patients who received salvage radiation therapy as opposed to adjuvant did worse. And this is shown here where the biochemical control rate was doubled in those who had adjuvant rather than waiting for salvage therapy to be delivered. And look at the difference in metastases and death rates. Once again, multivariate... Yes?
He included patients with PSA with persistent post-op.
Right.
Were they considered salvage or adjuvant?
They would be salvage, because the adjuvant had to have a PSA less than 0.2. Now, what I'm not sure about is what the lower limit of sensitivity was in the assay. I assume it was less than 0.2, but it may not have been. No. I mean, only 16% had adjuvant radiation therapy. This hasn't been published as a paper yet. It's only in abstract form, so we're somewhat limited in the detail. So multivariate analysis, once again, positive seminal vesicles, high grade, higher pre-radiation PSA were all adverse. But what is interesting to me is that the use of adjuvant androgen deprivation, which a smaller number got, did not come out as helpful, and nor did using a higher radiation dose than 60 gray. And the second phase 2 study I want to refer to is from Stevenson, also published just over a year ago. 500 patients, a whole mixture of patients from 5 different centers, a fairly mature follow-up, just under 4 years. And again, 17% had neoadjuvant hormone therapy, relatively short duration. And these patients did not do well. So this is consistent. Salvage radiation therapy, you're not going to do as well as adjuvant radiation therapy. Now, this could be just case selection. It could be that obviously you're only treating the guys with the worst disease, or it could be that if you just wait until the disease progresses, the chance of occult metastatic disease is much greater. When he looked at the factors predictive of progression, we see a pattern here. There's exactly the same factors, but the one I'd like to highlight is that if the PSA post-operatively was greater than 2, which is less than 1, there was a much worse outcome with a hazard ratio of 2.3. Now, ASTRO has some guidelines for the use of post-operative radiation therapy, and they actually recommend the use of salvage radiation therapy when the PSA is less than 1.5, and many of us would say less than 1 if we're going to use it, because otherwise we throw away this opportunity. Well, what about avoiding radiation using androgen deprivation? Lots of phase 2 data. There's a couple of phase 3 studies I'll refer to, but basically not a lot of good evidence. Again, from the Stevenson paper, the factors which were not significant with the use of short-term neoadjuvant androgen deprivation therapy, and again, a radiation dose did not seem to impact. Now, the RTOG9601 did a trial, randomized patients after radical prostatectomy to radiation therapy with or without Casodex. Now, the problem I have with Casodex monotherapy is that I don't think it is as effective as LHRH or orchiectomy, and so I'm not sure if they used the right hormone therapy. However, 840 patients were randomized, and we are waiting for the results of this trial. It was only closed a couple of years ago, so I would think we'll get results in a couple of years' time. But we have EPC data. This was the update of the second analysis published last fall by Worth. This is the North American trial results. There are two survival curves there. They are overlapping. You can just see out at 7 years there's a slight divergence, but there's basically absolutely no difference in a couple of thousand patients from the use of adjuvant Casodex. And in the European trial of watchful waiting, there was a statistically significant increase in deaths in those taking adjuvant Casodex, 25% versus 20%, which led to the withdrawal of the drug from the Canadian market. And in this North American trial, there is a marginal increase in deaths in the Casodex group. Judd Moore has presented from the Department of Defense Prostate Registry, which is a tremendous resource, a large number of patients. He was looking in this particular study at the use of hormone therapy. This is for patients with PSA failure, defined as a PSA greater than 0.2, reasonably mature, follow-up at 5 years. And you can see that he had about half the patients getting some form of hormone therapy and half not. And the overall results of this showed there was no impact from the use of hormone therapy on the development of metastases. But what's interesting is there was a subgroup analysis, and I don't quite understand this, but in those who had a PSA less than 10, there was an apparent benefit from the use of hormone therapy. That implies to me, because you can see from the steps in the survival curve, if I just go back, it implies to me that most of these guys actually had PSAs greater than 10, which is not, I think, what we would do today. Well, maybe it is. The difference, though, between these curves, particularly, ignoring the end of the curves where the data is perhaps not so reliable, but the difference in these curves is only about 1.5 years, perhaps 2 years. And so, of course, the guys who got the early hormone therapy and developed metastases generally would have had androgen-independent prostate cancer, as opposed to those who got the late hormone therapy who would have androgen-sensitive prostate cancer, and we would expect the androgen deprivation to work for about 18 months. So this may be an improvement in terms of metastases, but I don't think it's going to translate into a survival benefit of such magnitude, if at all. Now, this is a paper which just came out in the Red Journal, and it's remarkable. It's nothing to do with adjuvant radiation therapy. It's to do with the toxicity of hormone therapy. This is from Scottsdale, and Scottsdale, Arizona is a very unique urologic practice because everybody's very old, and they get treatment really when they don't need it. I mean, most of these guys, about 1,000 guys, got brachytherapy, and many of these were in their late 70s and 80s when they got the treatment, and we all know that most of these guys probably wouldn't be treated in North America. What they did, they looked at the use of hormone therapy because for downsizing and for other reasons, about a quarter, I think, of these guys got 3 to 6 months of hormone therapy prior to the brachytherapy, and then they were all followed until death. And remarkably, there was this increased death rate. This is the overall survival for the group, for the entire group of 2,300 men, and the 464 who got the 3 to 6 months of hormone therapy several years earlier had an increased death rate, overall detriment. And when they looked at the causes of death, they couldn't identify any one particular cause of death, but it was not prostate cancer. Virtually nobody in this study died of prostate cancer. The other interesting thing is the curves start to diverge around 3 or 4 years. So there's something that was done from this short-term hormone therapy which impacted on death rate. So a word of caution, hormone therapy, even 3 to 6 months, is not without potentially adverse toxicity. And we've seen that also in the Casodex study. Now let's just consider something else, and that's the patient's perspective, because this has all been physician-driven. Martin, do you want to do it first?
Well, if we could focus on that for one second, because this is still, that study is fairly direct
Oh, absolutely.
Be careful with extrapolating that kind of data. The EPC data in North America showed no absolute difference in overall survival with many more men in
Right.
controlled randomized.
But again, different hormone therapy.
Yeah.
And
So it was
this is very provocative. I don't know if it's true. It's almost too much of an effect to explain, but I think we just need to bear in mind that in the absence of evidence of benefit, we need to be aware that there may be detriment. It was LHRH. I just want to concentrate on the patient's perspective for a moment, because the men that you operate on are generally young because they have surgery, and they're still young if they have adjuvant radiation therapy or consideration for it. They're sick because they've been through surgery. And importantly, they chose a curative approach. They did not want watchful waiting. They did not want to have hormone therapy. They wanted radical prostatectomy. And so I feel that since we now have phase 1 data showing benefit, the issues of positive margins, of biochemical relapse, the clinical relapse, and the possible role of radiation therapy should be discussed with them, because many of these guys will feel that it should be discussed with them, because they're the sort of guys who want to be involved and they've chosen curative therapy. So, just to conclude this, and then I'll open this up perhaps to discussion, I think we have level 1 evidence that this at least is an acceptable approach. It leads to advantages in terms of biochemical relapse rates, and that may decrease the use of secondary hormone therapy with all the toxicity associated with that. We don't really know about the relative benefit of giving radiation therapy adjuvantly and giving it very early in the salvage situation at the first time of PSA failure. And so I think one should discuss with the patient the advantages and disadvantages of going early and as opposed to waiting until the PSA becomes detectable. And I think those who don't have adjuvant radiation therapy should be followed closely, and when the PSA becomes elevated, we have, I think, level 4 evidence from a couple of trials of benefit. And I'd argue that really we don't know the value of androgen suppression, at least in combination with radiation therapy. And I think adjuvant bicalutamide really is of no value. So, this is my last slide. Actually, it's not my last slide because I've got a couple of slides about trials proposals that are on the table, but I'll come to those later if we have time. I'd like us to consider these 2 points, that patients should be referred if they're TT3 or margin positive, except perhaps the sort of small focal positive margins which you can diathermy away and perhaps are really insignificant. And for those who don't have adjuvant radiation therapy, I think we should consider using radiation really early. If we're going to use it at all post-operatively, we want to use it early. Please don't wait and don't sit on the PSA going to 1, 2, 3, 4. Then it's too late. We need to see them really before the PSA is 1. Because, as we've seen, treatment is more effective earlier than later.